So small typo in the title. So I was hoping to have it corrected, but the correct title would be large pericardial effusion secondary to acute on chronic kidney injury, confounding a diagnosis of severe symptomatic mitral regurg. So basically, the background on this patient is this was a 55-year-old male, extensive cardiac history, including heart failure, hypertension, obesity, and chronic hypoxic respiratory failure. And he initially presented to our hospital in HCA Florida, Trinity, for evaluation of dyspnea after his home oxygen tanks were depleted. He was on chronic continuous home oxygen therapy. So in the initial physical evaluation, he had normal heart sounds, regular rate and rhythm. His lungs were clear to auscultation. Pertinent lab work on admission showed elevated troponemia. We can see the trend there, 21,464, 2,466, and then downtrended to 1977. And then he also had an acutely elevated creatinine 3.5 up from his baseline. Initial chest x-ray revealed multifocal ill-defined consolidations in the right mid to lower lung. The CT chest was done to further evaluate. This mainly showed cardiomegaly with a mild pericardial effusion and trace right pleural effusion. So at this point, a transthoracic echocardiogram was performed to further evaluate the suspected pericardial effusion. The echo showed, as we can see here, is EF of 45%, some diastolic dysfunction. And at this point, it revealed moderate MR. However, it did show a moderate to large pericardial effusion with no tamponade physiology. We can see the image here. In the cross section here, the effusion measured 3.17 centimeters, which would categorize it as large. The actual heart chambers didn't show tamponade physiology. So at this point, the differential diagnosis included the patient's end-STEMI, either this pleural or pericardial effusion causing symptomatology. He did have the moderate MR that was revealed that could cause some of his dyspnea. And then just in general, exacerbation of his heart failure. He did appear in a hypervolemic state. So he was optimized volume-wise with IV bumetanide. And at this point, and he was re-oxygenated with supplemental oxygen. At this point, the patient's symptoms didn't really seem to improve. And despite having no tamponade physiology, we kind of honed in on this large pericardial effusion, possibly causing one of the things these large pericardial effusions can do is cause just a mass effect within the mediastinum. It can cause symptomatology, including sensations of dyspnea, despite no tamponade physiology. So we spoke to our sister facility at Largo Hospital regarding possible cardiothoracic evaluation for resolution of this pericardial effusion, and they accepted a transfer. Upon transfer, they did a TEE to further evaluate. At this point, the valvulopathy was shown to be severe mitral regurgitation, and then it did redemonstrate the large pericardial effusion. So they determined that the valvular disease was most likely causing his worsening symptoms. At this point, he was taken for a surgical mitral valve repair. He had a ruptured chordae to P2, and then it was repaired with the annuloplasty ring. They did a thoracentesis for the pleural effusion. At this point, he improved clinically. His urine output began to increase, and he was discharged home. So it really was a culprit mitral valve with severe regurgitation. So basically, the conclusion of this study, of this report, this is a patient with multiple, cardiac comorbidities, kind of general symptom of dyspnea. Our main evaluation showed this large pericardial effusion that could be causing some of the symptomatology. However, was found to have severe valvulopathy with mitral regurgitation. Symptomatology improved with valvular repair. So, the main focus is the possibility of a large pericardial effusion confounding diagnoses of other cardiac pathologies, including valvular heart disease.